kind of included. Hey, Kirsten.
How big is the IWB organization?
I'll let Anna answer that.
Sure, yeah,
I am trying to get my microphone to work.
we can hear you now. Oh, maybe she can't hear us. But yeah, we have over 700 people signed up to learn about IWB. They're on our listserv from over 33 countries, which is very exciting. We started in 2020. I would say we probably have like 100 plus active members, but we have a lot of people interested and a lot of people on our Slack channels where we connect and post job postings, resources, things like this. So it's grown a lot. It's very exciting.
Nice.
Yeah.
Can you hear me now?
Yes.
Sorry.
Do we want to see if Kirsten can share her slides?
Yeah, go for it.
Just make sure we have that. Well, her video went out and she's muted, so.
Kristen, you want to try sharing your slides?
Kirsten, can you hear us, Kirsten? No? Okay, she's not hearing us.
Can you hear me now?
Yes.
We can hear you. Can you hear us?
I can hear you. Damn it. Can someone say something now?
Hello?
Okay.
You want to try sharing your slides real quick, Kirsten?
I don't read these anymore.
Can you hear us, Kirsten?
Yes, I can.
Okay. Do you want to try sharing your slides real quick?
Sure. Sorry, I'm trying to get them open. Hold on a second.
No worries.
How about I share a screen because my PowerPoint crashed. So let
That's
me share
fine.
a screen.
As long as we know you can share, we should be okay.
Can you see my screen?
Yes.
Okay.
Yeah.
Lauren, you want to remind them the order real quick, and then I'll.
Yeah. So just real quick before we admit people in. So one, Alexa's going to do an introduction just about IWB since this is linked with the monthly meeting. We're going to go through those slides. Then I will basically just do a quick little introduction and move straight into our speakers. So I have a little introduction blurb for each speaker. We'll start with Jessica, then Tisha, then Kirsten, and then Karen. The security settings for this, no one will be able to talk unless they are already a co-host, or be able to raise their hand. So questions will be going through the chat. I will tell everyone that if they have a question and they really like what's being asked, to thumbs up it. So at the end, we'll be able to get those questions answered. At the end, we do ask that you keep your camera on for a panel like discussion. So we'll have a couple questions generated and then be able to ask the questions from the group there as well. So any questions before we get started? Good, awesome.
All right, I'll disable the waiting room and have a great meeting all. Thanks.
Karen, I'm gonna post that tweet if you want to, where it's 65 people in the waiting room.
All right, thanks. I'll try and get it out to GCMAS.
Thanks. Hi, everyone. Thanks for joining us. We'll get started in just a second as people kind of trickle in from the waiting room. Alrighty, I think we're gonna go for it. So welcome to our November monthly meeting. My name is Alexa and I'm the communications director for IWB. I'm gonna do some quick announcements and then we will get started. Just so you know, because this one is live streamed, nobody can unmute themselves. So all questions that you have for speakers, we will just post in the chat and remind you of that kind of as we go on. To get started, if for some reason you have any issues and you can't get back in, we may reach our limit of people. So there's a YouTube live stream that is going on. If you have any issues, you can always check the YouTube live stream. We just tweeted it out. That's posted in the chat. If you have friends, colleagues, anybody else who also wants to hop on, we're about 10 people, 15 people away from our limit. So I imagine that we will get there. Just a quick introduction about IWB for those of you who are unfamiliar or coming from the GCMAS side and may not have heard from us. We are a nonprofit that works as the International Women in Biomechanics group. We're here to see kind of how international biomechanics community that supports women and non-binary and gender non-specific individuals, and we want that community to be a level of respect that values and supports gender equity within biomechanics as we work towards that, but also creating a community and a place of support for women and underrepresented genders in biomechanics. If you want to sign up to our wonderful community, you can fill out our member form, which is now also in the chat. We have members from all over the world representing over 30 different countries and over 700 members that kind of exist within our reach. We have a pretty active Slack community networking these monthly meetings that happen, but other resources that we share and posting a lot of jobs and career support, professional development, and just finding a place where women and underrepresented genders can share and communicate with others in what is a safe space for them to do so, which mostly happens on our Slack. We're also developing a membership platform on our new website that's coming very soon. So some kind of steps up in the world as we go. But we would love to have you join. If you don't consider yourself a woman or an underrepresented gender, you can also join our community as an ally, and we love to have those as well. And those newsletters and such go out regularly.
Awesome. So I'm going to talk just a little bit about GCMAS. So we're really excited for this IWB meeting to be inviting in collaboration with the GATE and Clinical Movement Analysis Society. So this group is made up of multidisciplinary organization of physicians, allied health professionals, engineers, biomechanists, and scientists that are all working together to help advance scientific knowledge, technical capabilities, as well as clinical practice. We do have our annual conference coming up. So if you are enjoying a lot of the talks that are given today and are wanting to kind of find out more information, please join us. I'll put a membership, how to become a member, in the chat, but we will be having our annual conference June 16th to 18th at Georgia Tech in Atlanta. There is going to be a pre-conference, a pre-course that is made up of clinical and technical tracks. So if you're kind of wanting to understand more about gait analysis, how maybe clinicians view that information, how it helps inform clinical care, or more of a technical track where you're wanting to sit down and learn how to develop your model and go from there. So one, make sure you follow us on social media. So we are on Twitter, GCMAS. I will put in the chat about membership. This is also open to students. So if you are a student that are kind of going through, feel free to join. At GCMAS, we have a student organization, a student committee. So I'll put my email in the chat if you're interested in joining that as well. Perfect.
Awesome. Thanks, Lauren. Quick announcements for us. We just want to save the date for National Biomechanics Day coming up next year on April 3rd. Obviously, this is completely National Biomechanics Day is fluid days on whatever works for your lab or your clinic or whatever situation you are in that you can do it. But we are claiming working the National Biomechanics Day is April 3rd. And we work very closely with NBD and kind of some of our future stuff. So expect to hear some things coming out from that shortly. For our speakers for today, need a quick introduction. So we have Dr. Jessica Lewis, who is from Nationwide Children's Hospital. We have Dr. Tisha Wren from the Children's Hospital of Los Angeles, Dr. Kirsten Tolchin-Francis from Nationwide Children's Hospital, and Dr. Karen Kruger from Shriners Children's in Chicago. They are going to share with us all of their GCMAS and biomechanics clinical knowledge today. And our last thing is save the date for our next meeting, which is on December 6th at 4 p.m. in GMT Mountain Standard Time. And it will be an IWB holiday season quiz, as we tend to do a holiday type of meeting in December. There'll be future information that will come out. You'll see that on Twitter and at Slack in the coming weeks. I'm gonna leave it there, and I'm gonna turn it back over to the GCMS crew to start their presentations.
Perfect. Thank you so much, Alexa. So hi, everyone. My name is Lauren Luginsland. I'm super excited for this collaborative webinar series today with IWB and GCMAS. So I am currently a PhD candidate at Old Dominion University. I'm currently investigating gait analysis in persons with autism spectrum disorder. Prior to starting my PhD, I was actually a biomechanist in the movement science lab at Scottish Rite for children in Dallas, Texas. And that's kind of where I became really involved with GCMAS Society. So each of our invited speakers today are GCMAS members that utilize motion capture technology to directly influence clinical decision-making, including surgical interventions and post-surgical rehabilitation at their institutions. So we'll have 4 speakers for today that will talk for roughly 5 to 7 minutes. So this is going to be just a little sneak peek behind the research that they all do at their institution. What we will do for today is, if you have questions for each speaker, please put them in the chat. So feel free to type up those. If you like someone's question and you really want that one to be asked at the end, please make sure you thumbs up what that question is, and we'll make sure we prioritize the questions. So following everyone's chat, we will kind of get together and do a little bit of a panel discussion. But with that being said, without further ado, I'm going to hand it over to Jessica Lewis. So while she is pulling up her slide, I'll give a quick introduction. Jessica Lewis is a licensed physical therapist in the Honda Center for Gait Analysis and Mobility Enhancement at Nationwide Children's in Columbus, Ohio. She completed her physical therapy degree and a postdoctoral residency at The Ohio State University. She is currently a PhD candidate in health sciences at Rush University. She has worked in the game lab at Nationwide for the last 5 years and has a special interest in clinical gait and spine analysis for children with neuromuscular diagnosis. She's going to be kicking off our webinar today and discussing helpful tips that she has picked up working in a clinical setting. So here we go, Jessica.
All right, just to make sure everyone can see my screen, okay? Okay, perfect. All right, so I'm just going to briefly touch on kind of the world of physical therapy, mixing in with the world of biomechanics. There we go. All right, so just a brief little information about kind of what a physical therapist does in a gait and motion analysis lab. So we bring children in of any kind of diagnosis, and we do a little bit of an assessment with them. So it could be gait, it could be spine. We might look at EMGs, kinematics, kinetics, pedobarography, and do a physical exam looking at range of motion of all kinds. So we put all of this information together to kind of get an idea of how the child is walking and moving. So in school, you most likely learn the importance of how reliability of like putting on markers, of assessment is super important to get really good data. The nice thing about school is you're in a perfect environment where you are practicing on your peers. Most likely your peers were able to kind of sit there, let you put markers on them, let you evaluate them, and then the data that you got from them was nice, solid data. The graphs looked great, not a lot of variability in their walking, and kind of easy peasy, you got that data out. But working with children, especially children with different levels of ability to follow directions, different cognition, different abilities of walking, makes it a little bit more difficult to get really good data in a motion analysis lab. Their anatomy might be a little bit different, attention spans, depending on the age. Mine's not great, and I'm a little bit older. So little kids, it's even harder sometimes. It's hard to get kids not to do a doctor walk. They have all the crazy things on their body. And so it makes them feel like they're walking a little bit like they shouldn't be. So getting them to walk like we want them to makes it that a little bit difficult. And then just children who have difficulties walking in general. So just try to imagine putting all 40 of these markers on maybe like a 5-year-old child that has problems with sensory, maybe difficulty sitting upright, because of poor postural control. They're in a weird environment. They just want to kind of sit next to their mom because they're a little bit afraid. Other doctor's appointments haven't gone well for them. They're afraid of needles. You might be putting a needle in them. They're worried about it. So this child who's kind of looking at you like this, how do we keep them from hiding behind their mom? How do we keep them from getting a little tearful? Or how do we prevent that full-on meltdown? So we just want to try to have these kids have fun in an environment that is kind of clinical, very different from what they've ever experienced before. So just using kid-friendly things like playing games with them, asking them fun questions. In school, you probably didn't have to ask your peer what their favorite color was or what the name of their cat was. But kids kind of enjoy talking to you like that. So just kind of having those kid-friendly conversations, making them feel comfortable. I'm not above giving little prizes or saying they get a sticker, using iPads, using parents, anything that's reinforcing to kind of help get your markers on in a good way, get good data, kind of using that. And then ultimately we want that happy kid in the end while they're participating in your lab. We also need to remember that these kids, they're kids. We want to talk to them like they're kids. We don't want to talk to them like they're babies. Just because a person, a kid, a young adult, a young teen might have problems with their walking, that doesn't equate to having problems with the way they think and the way they want to be spoken to. So just remembering that we should treat them like a human being talk to them on a level that they should be spoken to, and then asking them kind of appropriate questions if, based on their age or level of understanding. If they do have a cognitive impairment, then it's important to also make sure you give them plenty of time to respond to you, to answer your question. If they're nonverbal, that doesn't mean they don't want to talk to you. You just kind of, it might be a one-sided conversation where you're getting their answers from their eyes or from their nonverbal cues. So just kind of remembering to treat all children like children and not like something that you have to kind of tiptoe around. And then also be careful with the language that you use. Always try not to use the word walk like a normal child up and down the line. Parents have probably been told your child will never be normal more times than they want to hear. So avoiding any kind of language like that is super important. You can always just say, walk like you would with mom at the grocery store, walk like you would with your friends at school. When you're comparing their data, you could just say children, peers of their own age. So just avoiding language that might be hurtful for the family because they've only heard it in negative ways. And then marker placement for these children. So this is like the perfect skeleton. You can kind of see a lot of the bony landmarks where you might want to put markers, where you might not want to put, where you want to avoid putting markers. So this is kind of the ideal skeleton and bony anatomy that we practice in school. But then when we get into a clinic and working with kids with musculoskeletal disorders, these are kind of the skeletons that we see. So their hips might not have great stability. Their bony alignment may not be what we're expecting. They might have a scoliosis. You can kind of see some of the pelvis is shifting. So you really have to be careful about how you're putting these markers on. You have to try to make a child feel comfortable in their own skin. They might kind of know that their body doesn't look like their peers. Their body might not look like you, but you have to get down to their skin. So they're wearing less clothes than they might want to. And so just kind of making them feel comfortable, really working hard to get good marker placement so we can get good data that eventually leads to the research that we do with the data that we collect from these children. So just kind of to wrap it up, reasons why I kind of love this job and love working in a gait and motion analysis lab in biomechanics. The main reason is kids are fun. So they're my favorite population to work with. You never know what they're going to say. They always say something funny, different. You're not expecting it. And every kid is different. The interdisciplinary aspect of working in gait and motion analysis labs is really amazing. You get to work with physicians from a lot of different disciplines, working with engineers, working with different students coming into shadow. So you get to meet a lot of different people, see things from their views, answer a lot of questions, ask a lot of questions. So the learning is kind of nonstop. Mentorship is really great. Within the lab, lots of opportunities for learning from different people, have some really great mentors, research opportunities and collaborations. So collaborating with other gait labs, it's a small world and everyone's really willing and very friendly and wanting to kind of share what they're doing and kind of helping you with your research as well. So it's a really great community and getting out all the data and then kind of trying to help the kids that we are working with our recommendations and our findings and our research. So that's just kind of a little bit about PT and a little bit of a teaser for what these other ladies are going to be talking about with their presentations. So I'm going to go ahead and stop sharing, and then I believe I'm going to pass it off to Tisha.
Awesome. Thank you so much, Jessica. So there you have it. It's really important to have the perspective of clinicians, especially that work in these labs as well. So thank you very much for your presentation and kind of setting the foundation for these next talks. So if you all have any questions for Jessica, please put them in the chat and we will make sure we get those addressed. So we're going to go ahead and pass it off to Dr. Tisha Wren. She is going to set up her slides here. So Dr. Tisha Wren is the Director of Research for the Jackie and Gene Autry Orthopedic Center at the Children's Hospital of Los Angeles and an Associate Professor of Research Surgery at the Keck School of Medicine at the University of Southern California. She has won the Best Paper Award for the Pediatric Orthopedic Society of North America, the Gait and Clinical Movement Analysis Society, and the American Academy of Orthopedic Surgeons. And she has served as one of the past presidents for the GCMAS Society. She continues to be a huge advocate to help eliminate the barriers of access for pediatric gait analysis. So with that, we'll turn it on over to Dr. Tisha Run.
Okay, thank you. So my topic is focusing on sports medicine and biomechanics and how those interact. So I'll mostly be talking about our sports biomechanics testing, which happens in our motion analysis lab. It's kind of a typical motion lab. We have the infrared cameras, video cameras, force plates. So, within this environment, we do motion analysis testing, kind of as has already been presented, but our young athletes come in, they do various movements. And from that, we develop the biomechanical model. And then from there, we get kinematics and kinetics throughout the movement cycle. And for clinical purposes, we have a scoring algorithm that we give a score to the patient based on their kinematics and kinetics. For some reason, the videos are not working. Okay, there we go. So these are the different tasks that we test. We have 6 scored tasks and then treadmill running, and we recently added a one-leg vertical hop. So again, from this from these data, we have obviously the person moving, we have the skeletons, and then we have all the data that's generated, and we look at particularly individual data points that are of interest for each task and develop the scoring matrix. And that information for clinical purposes is used to guide rehabilitation. What does the patient need to work on to be ready to return to sport? It's also used for that clinical decision making of, are they ready to return to sport? When should we return them? And so this data are used directly for clinical purposes. And I just want to highlight a couple of the research studies that we've done. Most of this research is done with the same clinical data that's collected with patients or from control subjects who are without injury, who undergo the very similar type of test. So one study is looking at the intertrial variability or trial-to-trial variability within the same participant doing these different sports tasks. This one looked at 55 uninjured control subjects doing the drop jump, the heel touch, and the single leg hop. And we just looked at the standard deviation and the range of difference between those 3 trials. And we looked particularly, we're comparing preteens versus teens. And again, we're focusing on trial-to-trial variability. And the first thing we noticed was that in general, variability is higher for preteens. So they have a less developed motor system, so you can see the points are more spread out along the vertical axis, which is the range of difference. So you can see that there's quite a bit of difference between just 3 trials, between the highest one and the lowest one, especially for some of the preteen athletes. But also we noticed that in the single leg hop, there was a very high variability for the teenagers, the older patients, or the older subjects in the sagittal plane. So we think that this has to do with having a larger mass and being taller and having to control that, and that there's a lot more just sagittal movement to be able to land this single leg hop. So this variability is something that then we need to be aware of when we're doing the clinical tests and when we're doing the interpretation. So one way that has changed our practice is that we use all 3 of the trials that we collect, and we look at the average and the variability of all 3 trials rather than using just one, which is what we were doing originally. And then the second study that I'd like to highlight is this study on opticity symmetry. So This is a common test that's done in the clinic because it's pretty simple to do. You don't need any equipment to do a hop distance test, and what you do is, just have them hop as far as they can on both legs and compare the two. It's usually considered to be symmetric if they're within 90% of each other. So because we're doing this in the motion lab, we have more data that we're collecting. But the first thing we noticed was that when we look at controls compared to post-ACL reconstruction patients, there's almost the same percentage that were symmetric in both groups. So the patients were not more asymmetric than controls, and quite like a third of controls are asymmetric by the 90% threshold. And if we look at the hop distance, this is what we expect to see in the asymmetric group, where the injured side is hopping a shorter distance than the uninjured side. But when we look at the symmetric group, we can see that the reason that they're symmetric is for a large part because they're hopping a shorter distance on the uninjured side. So they become symmetric not by hopping the normal distance on the injured side, but by reducing the performance on the other side. And then when we look at the kinematics and kinetics, we can see that the patients are offloading their reconstructed knee, whether they're symmetric or asymmetric in their hop distance. And if you look especially at the moments and the powers, you can see the solid line is the injured side, and the red line and the blue line are both below the black, which is the normal. So whether they're symmetric or asymmetric, they have reduced knee moments, and on the bottom also reduced powers. And really the difference is being seen on the uninjured side. So from this study, it reinforces our our thought that the hop distance symmetry isn't really a good metric for indicating normal biomechanics, and it also doesn't tell us about return to sport readiness. And we feel like you really need to look at the kinematics, and especially the kinetics are very revealing. So I just like to emphasize, I think you'll see here today, the interplay of biomechanics, clinical care, and research. Our biomechanics is being used, as you saw, directly for clinical care. It's also being done for research purposes, and our clinical care informs the questions that we ask in research, and research results then feed back into how we do clinical care. So I think I'll leave it there and turn it back to the organizers. And this is
wonderful. Oh, yeah. Perfect. Wonderful. Thank you so much, Dr. Wren. All right, so our next speaker, I'll let her get her slides set up and ready, is going to be Dr. Kirsten Tolchin-Francis. She is the director of the Orthopedic Research and the Honda Center for Gait Analysis and Mobility Enhancement Laboratory at Nationwide's Children's in Columbus, Ohio. She has 25 years of experience in biomechanics, studying how children and young adults with ortho and neuro conditions move. She has been recognized as an outstanding researcher in the area of STEM by the D Magazine Healthcare Innovator of the Year, and If Then Ambassador for the American Association for the Advancement of Science, and the Women Who STEAM Award. She's involved on many different boards within pediatric and orthopedics, and is currently the past president of GCMAS. So without further ado, I'll turn it on over to Kirsten.
Great. Are you able to see my slides okay and hear me?
Yes.
Excellent. So I'm going to talk a little bit about spinal deformity and how biomechanics and motion capture can be used clinically in this kind of different patient population than I think a lot of us are used to seeing. So I think when it comes to spinal deformity, we're probably used to, our first thought comes to mind as our kind of typical adolescent idiopathic scoliosis. So that kind of lateral curvature for the most part of the spine. But I think what's important to remember is that this spinal deformity is actually three-dimensional. So you're not only seeing a lateral shift of the vertebrae, you're also seeing a rotation. And then also in the sagittal plane, you can also see either hypokyphosis, or lordosis as well. So this kind of 3D thought of what's going on, and the fact that the main treatment for this tends to be, in severe cases, fusion, how does that affect movement and motion? So not only is there adolescent idiopathic scoliosis, but I think one of the more understudied groups, and especially in terms of biomechanics, are more congenital and neuromuscular patients. So there's a lot of different congenital deformities, specifically in vertebral body formation, that can cause deformity not only in the coronal plane or in that scoliosis curvature, but also in terms of that kyphosis, increased kyphosis or decreased kyphosis, and lordosis as well. So we're seeing these formations, and these are really complex patients that have a lot of underlying pathology a lot of times that we have to take into account as well. You also can see things with Schuermann's kyphosis, or maybe in a more athletic population, you might see something like a spondylolysis, which is going to be a fracture in that pars, or a spondylolisthesis, where you're actually going to have a slip of the spine kind of off that sacral joint. And depending on the severity of that, that might be treated with surgery or more non-surgically and conservatively. So in a really severe case of scoliosis like this, 3D printing has come a long way with us looking at that spinal deformity and letting the surgeons and the orthopedic surgeons get their hands kind of like on that spine to understand the positioning of it. And then they can put in their instrumentation and correct. But the question remains is, how does this affect outcomes in terms of functional ability? So if you could imagine a patient who is neuromuscular, who has a diagnosis, say, of myelomeningocele, or spina bifida, those patients often need to do, self-cathing and caring for just self-care. And if you fuse them all the way up to, say, T2 or T1, you're going to have difficulties maybe being able to provide that for them long term. So I think, it's really important to understand the outcomes of treatment and understanding what limitations, if any, there are, and how they can kind of combat that. So our approach has been to start to see some patients clinically. We can look at the kind of biomechanical factors that go into spinal deformity. So you have your anatomical factors, meaning abnormal bone growth or just imbalance of muscles, tendon ligament differences in terms of stiffness or laxity. You can also have your neurological factors in those patients with underlying disorders or syndromes. So they could have weakness, spasticity, and tone, or just a general lack of motor control. But ultimately, what this can relate to is a change in posture. Now, whether that's a structural change, meaning they have a trunk shift, or whether that's an inability to have good postural control is another question. But that leads to abnormal loading within the spine, which can then enhance spinal deformity and severity and lead to spinal instability. So in analyzing spinal motion in more of like a motion capture lab of what we're used to, you can do a typical gait analysis in those patients that are ambulatory and look at the same kind of things that we typically look at with general clinical gait analysis in terms of temporal spatial parameters, kinematics and kinetics of both the lower and upper extremity, as well as the spine. And I'll look at that in a moment. You can do some postural control. So this is really important in patients that are treated non-surgically. So for AIS, patients who may be undergoing Schroth treatment. So that's a specialized physical therapy treatment that really focuses on proprioception and posturing of the spine and using those muscles to help control and the positioning of your spine. So that's postural control within a gait lab would be great to use pre and post Schroth, or even during Schroth, to see, giving them real-time feedback on how well they're doing. Movement coordination. So again, this is kind of where I'm talking about having, you have a spinal fusion, now what? So where are you losing range of motion? Where are we gaining range of motion, and how is it impacting our ADLs? I think that's a really important outcome measure that we can look at in terms of our patients in biomechanical analysis. And then lastly, more advanced modeling techniques. So you can use computer simulations, you can combine with imaging, and I'll talk about that in a moment as well, to look at the loading of the joints within the spine, also looking at the altered muscle activation that goes back to our postural control as well. So in terms of spinal motion capture, we have, there's not really one or even two set ways to do this. That varies. So here's some examples of looking more at segmental motion. So looking at kind of a thoracic motion and lumbar motion relative to the pelvis. You can also look at total spinal motion from the cervical segment down to the pelvis. There are other approaches to this where you have multiple markers to split the split the spine up into different segments. So you can have upper and middle thoracic or lower and upper and middle lower lumbar segments. And then you can go as far as maybe even putting marker sets on every spine. I think one of the main caveats to all of this is to realize that you need to be cautious with how many markers you use on the spine. There's a lot of skin motion that's occurring of the bones underneath the skin. So how you're tracking this motion is incredibly important. So sometimes simpler is better. And then combining all of this with imaging and some computer simulations will give us the ability to look at things like loading at each lumbar joint. This is great research that's come out of OSU that's looking at things like low back pain in adults and how that is translated from deformity to pain to function. So I think that's really great research. The other thing I will say is there's a lot of clinical applications of this. So I think treatment planning, we have been using this now in our lab to help them determine, if a patient, where a patient should have their lowest instrumented vertebra. So again, should they go down to the pelvis? How is that going to affect the ambulatory function of a patient with neuromuscular disease if they fuse down to the pelvis or not. So surgical decision-making in that regard, I would say I don't see motion capture being able to tell you whether or not you should do surgery, but maybe some of the nuances of where the fusion should take place will be really important. Monitoring outcomes long-term, I think this is another way that we can use this clinically to understand the outcomes of our treatment, both surgical and non-surgical. Preventative medicine. This is a huge group here of patients who have low back pain, and that's in both children and adults. And how can we improve biomechanical techniques in picking up things from the ground to improve low back pain and their biomechanics. And then honestly, patient education from a pediatric standpoint, patients going into surgery who are going to have a fusion, it's really great information to provide to them on what to expect in terms of function when they get out of surgery. And at the center of all of this is research and development. And then not only research on the clinical outcomes, but also development of new techniques. So really supporting the use of Schroth with bracing, looking at different new surgical instrumentation and tethering techniques, which are non-fusion techniques versus fusion techniques. So there's a lot of research that can be done to kind of quantify and further develop the field of treating patients with spinal deformity. And I think the clinical kind of future for this, just to wrap up, would be one is this technological integration. So merging imaging, because all of these patients are going to get imaging of some sort, whether that's X-ray, CT scan, MRI, some combination thereof. Combining that with the kinematic assessments, looking at muscle synergies and the role that muscle imbalance may or may not have in that particular patient. And then ultimately doing computer simulations to look at vertebral loading at the individual joint level. And then really taking this analysis out of the lab and into the clinic. So can we use things like markerless motion capture even in the hallway at the clinic, or wearable sensor technology and activity monitoring to track how these patients are doing and progressing throughout their treatment process. So I think there's a lot of great areas that clinical biomechanics can come into play with spinal deformity, and happy to talk about that later. Thanks.
Fantastic. Thank you so much, Kirsten. Those were really great points, especially out of the lab. I think that's going to be a question that's coming up in our panel discussion in quite a bit. So just a reminder, if you have any questions along the way, please make sure you insert them into the chat. With that being said, we're going to introduce our final speaker, Dr. Karen Kruger. She is the Director of Motion Analysis Center at Shriners Children's in Chicago and a Research Assistant Professor for the Joint Department of Biomedical Engineering. She is a key faculty member of the Orthopedic and Rehabilitation Engineering Center, which is an effort between the Medical College of Wisconsin and Marquette University. She is an avid IWB member and currently serves on the GCMAS board as the chair of the membership council. So I'll turn it on over to Karen.
Thanks so much to Lauren for organizing this and to the rest of the IWB committee for letting me talk about some of the research and clinical care that we're doing here between Shriners Children's and Marquette University. So first off, for people that aren't familiar with clinical gait analysis, I just kind of wanted to show an overview of what our lab looks like. So our team at Shriners Children's in Chicago consists of 4 physical therapists and 2 biomedical engineers who share the same lab space. So we really are working together on a day-to-day integrative basis. We also meet at least weekly with a team of orthopedic surgeons, PM&R physicians, and in some cases, orthotists, to review the patients that we're seeing in the lab, and really have a true multidisciplinary approach, consisting of the orthopedic surgeons, physical therapists, and engineers coming together to plan out the best course of intervention for each children. And as an engineer, I really never thought that I could be this integrated into clinical care. So that's one of the things that I've really loved about being involved in motion analysis. So Jessica really hit nicely on kind of what is involved in this clinical case review. And I think a lot of us do something pretty similar, where we have kids instrumented with markers to collect their kinematic and kinetic data. And that's combined with a physical exam completed by one of the licensed physical therapists. And I'm here to talk mainly about how we look at the foot specifically. So these markers show a standard lower extremity marker set that would be used as part of a routine clinical joint assessment. However, if we look at the foot, we can see generally only 3, maybe 4 markers are trying to represent the motion of the entire foot. And anyone who's ever tried to analyze the foot knows that it's not a single rigid segment. There's 26 bones in each of your feet, so modeling them as a single rigid segment and trying to get any sort of clinically useful information out of that is difficult. So there's a variety of segmental foot models that break the foot into either 2 or more segments that allow us to do this in a way that's clinically useful and we can implement in our routine gait analysis. So the model that we've been using for years is the Milwaukee foot model that breaks the foot and ankle into 4 segments: tibia, hindfoot, forefoot, and hallux segment. And what's unique about this model is we combine X-ray imaging data, because one of the tricky things with working with the foot, and I think this has been stressed in a few of the other talks, is with marker-based analysis, we're relying on anatomic landmarks that are easily reproducible. And in the foot, they're not always identifiable, especially on the calcaneus. And the other thing with the foot is some of these segments are so small, so any marker placement errors you have are going to be amplified. So we're able to combine this marker-based data with our imaging data that's collected as part of routine clinical care to get more accurate tracking of the foot and get the actual bony alignment of how these kids are walking. So we've used this for a variety of applications, both in clinical and research care. So during clinical care, we first and foremost use it to identify atypical segment motion during walking and intervention planning. On the research front, we've used it to look at populations of kids within a same pathology and use the segmental foot data to identify kinematic subgroups within a population. And then we've also been able to use it to actually measure the effectiveness of an intervention. So if we're using a clinical gait analysis to inform our clinical care, we then want to look at the postoperative results to see, did the surgery actually reach the goals that we were going for? So both clinically and research, we've seen a huge number of patient populations, both at our lab at Shriners Children's in Chicago, and then up with some adult collaborators at the Medical College of Wisconsin, from deformities like cava varus, equina varus, plana valgus, or hallux valgus or rigidus in the adult populations, and a variety of clinical populations, including clubfoot, CMT, and cerebral palsy. And I would love to talk about more of these research applications, but Lauren only gave me 5 minutes here. So if anyone is more interested, we just gave a GCMAS webinar on a lot of these research applications. So if anyone is interested in seeing that, that is available to GCMAS members. So please reach out to me if you're interested in seeing that. But what I wanted to spend more of my time today was just going through a clinical case example about how we pull this segmental foot and ankle data together with a physical exam data and use it to guide patient care. So this patient that you see walking here is a 12-year-old male diagnosed with left hemiplegic cerebral palsy, GMFCS level 2, meaning he can walk independently but has difficulty walking on uneven surfaces or up and down stairs. We tend to start our case reviews with the chief complaint. And in this case, the patient and the family were most concerned with frequent tripping and falling, as well as lateral foot pain, which watching him walk, you can see how he would be having pain in that area. Previously, he had undergone a tendo Achilles lengthening at 1 year of age before coming into care at our hospital. So first of all, looking at the segmental foot kinematics, this top row here shows our hindfoot segment, or the articulation of the hindfoot relative to the tibia, and the bottom show the forefoot, or the forefoot relative to the hindfoot. So just taking a look at these, the foot that we're most interested in is the left foot, which is shown in blue here. So first, looking at the sagittal plane of the hind foot, we can see this huge shift on the y-axis toward plantar flexion, and we only see that in the hind foot. We're not seeing any sort of deviation in the forefoot. Then moving on to the coronal plane, we see this shift toward inversion, and we see a similar shift in the opposite direction on the coronal plane of the forefoot into valgus. And we want to be careful looking at this, because while we're seeing a deviation here, the fact that the hindfoot is inverted, this forefoot valgus we're seeing is very likely a compensation for that motion. So if we're able to correct the hindfoot positioning, this forefoot could very well end up following that correction. So I mentioned that we will also combine this with a physical exam data, looking specifically at the foot. We look at the ankle in dorsiflexion with the knee both extended and bent to 90 degrees. And looking at these differences in the R1 and R2 values, we can see that there is likely a joint contracture here, causing that stiffness at the ankle joint, which we saw on our sagittal plane hindfoot kinematics. Then looking at the hindfoot and forefoot inversion, eversion, AB, adduction, we can see that there was a position deviation during walking. However, upon physical exam, the PT was able to assess that that deformity was supple and correctable with repositioning. So that led our clinical team to recommend that a soft tissue procedure, as opposed to a more invasive bony procedure, would likely benefit this patient the most. So following the case review with that interdisciplinary team I talked about, this patient received a left tendo Achilles lengthening and then a left split transfer of the posterior tibialis in order to correct both that ankle stiffness that was identified and also the abnormal hindfoot coronal plane positioning. So first off, just taking a look, we have the preoperative on the left and postoperative on the right, and we see this was a really nice correction where the foot position is significantly improved, and the mobility also looks significantly improved. But then, as I said earlier, we also want to look at our segmental kinematics to see quantitatively were these surgical goals accomplished. So here we have the preoperative plots in purple and postoperative in blue. So we can see that plantar flexion shift was almost completely restored to within typical limits. And then by correcting that hindfoot positioning in the coronal plane, we see this inversion and valgus were both significantly improved to almost typical values. So that's all I've got. Since I'm speaking last, I just want to make one more plug for our 2024 GCMAS annual conference. And if anyone has any questions for me, please feel free to reach out.
Awesome. Thank you so much. These were great talks, and we really appreciate that. It seems like we have quite a bit of questions from the group, so I'm going to invite our speakers to come back on. The first question is going to be, is there an interest or a push for the use of markerless motion capture techniques in the clinical setting? What challenges would you foresee implementing this new technology? So this is open to anyone to answer first.
So we are using it at Children's Hospital Los Angeles. We have the Thea markerless system, and we're collecting simultaneously marker-based and markerless. Right now, we're looking at validating accuracy for clinical decision-making. We're not convinced, especially in the transverse plane, that the markerless data is giving us good transverse plane data, which is used for clinical decision-making, both for clinical gait analysis in neuromuscular disorders and also in sports. So I think that's the main question, is how do the systems compare, and, are we getting those measurements that we need to do decision-making? We have used it for some research applications where it was just much easier to do the markerless, so that was like things like ballet, where it would be much more difficult to put markers to go bring our system out to the, to the dance studio and do all of that. So we have used it in other applications. But I think our biggest hesitation is if we're going to make clinical decisions using it, we have to be confident that it's showing us the data that we need to do that.
Yeah, I would agree with that as well. I think that the comment about transverse plane, I think in the presence of significant deformity, whether that's lower extremity, upper extremity spine, I think that we just want to make sure that it's as accurate as we hope it is before we get to that point of clinical decision making. But in my eyes, I think that in a long-term situation, it can be something that can be used for clinical care at some point. I'm just not sure. I'm not convinced we're there yet, but I have optimism, which is a big change in my opinion from a few years ago.
Awesome, thank you. Kind of a popcorn question off of that. Since the data that you all collect is used to inform kind of surgical decision making, the data obviously needs to be very accurate. Can you talk a little bit about what you all do to make sure the data in your lab is as accurate as possible?
I mean, from the first standpoint, I would say, competency in staff and good equipment Q&A are the two big things for me in the first part, which is just general operations. So kind of following CMLA ideology there, and making sure that you have equipment QA programs in check, and you're making sure your equipment is functioning in a real-time basis, each and every day. But then also staffing competency. I feel like that's one of the areas that we spend the most amount of time on, making sure that our clinical staff that are putting on markers, or our research staff who are putting on markers, are repeatable and accurate, and we're getting the same thing every time, no matter who's doing it. I think that's a big part of it. And then from the spine side is just trying to make sure that what we're seeing is real, and that our models are accurate. And that's difficult to do because we don't have a gold standard, unless you're looking at something like a spine flexibility in x-ray or something like that. It's hard to kind of have that gold standard, because honestly, motion capture tends to be the gold standard for things, right? But understanding that is a big part of it.
I would just kind of echo that, and making sure both the engineers that are implementing the model really have an understanding of what the important aspects are, down to marker placement and how that can impact your ultimate clinical calculations. But also, if you've got clinicians that are either putting on markers or interpreting results, have an understanding of that model. So if they're seeing something that's not right, you're able to work together to identify, is this actually something real we're seeing, or is there a possibility that a marker placement could be causing that error?
Wonderful, thank you. And I know an acronym that was just used was CMLA. So for those that aren't quite sure what CMLA, it's the Commission for Motion Laboratory Accreditation. So I'd also recommend checking them out online as well. All right, moving on to the next question. It says in the chat, successfully integrating biomechanics into clinical pathways obviously requires very multidisciplinary expertise, most likely from a team that includes both clinicians as well as non-clinicians. How do you best manage the required knowledge sharing within your wider teams? What barriers, if any, have you found to getting buy-in from clinicians, and how do you best overcome that?
Honestly, I echo what Karen just stated. I think that, I've been in this field for a long time, and there's always been this idea that we have a clinical team and we have a technical team, and they're segregated. And I feel really strongly that that's not the right approach to it, because that's how you share information between clinicians and non-clinicians. There has to be a basic understanding of everything, of everybody, and then they can have their specialty. I think that also bleeds over into getting clinician buy-in, because they need to understand what you can provide them in terms they understand that can make a difference in their clinical decision making. So I can't go in as an engineer and present this ridiculously complex technical stuff, and if I don't put it on a level that's going to relate back and translate to the bedside. So I'm not saying take out the technical stuff. I'm like, make sure you can translate it into the bedside manner so that they can understand it and implement it clinically.
Yeah.
And I also think, oh, sorry, go ahead, Tisha.
Go ahead.
Oh, I think it's important during like the interpretation sessions, if you have those as the interdisciplinary team, to make it as welcoming and as open as possible, so people feel comfortable asking questions and kind of bouncing ideas off of each other. So like an atmosphere where no question is a bad question. So just that communication piece between all clinicians or non-clinicians in the meetings.
Yeah, and I think one aspect of that communication is just kind of learning the lingo of the other side so that you're able to communicate back and forth. But I do think also for getting clinical buy-in, I think having good data helps. If you can show a clinical person, evidence, they don't necessarily need to know all of the technical details to be able to see that. And I think, having actual data is stronger than, just telling them something. So I think having that sort of quantitative backup is also helpful for getting clinical buy-in.
Wonderful. So I think we have time for maybe one or two more questions. One of the questions in the chat is interested in how your time might be split between clinical case reviews and conducting research studies. Is it a 50-50 or some other type of division? And then it says, thanks, Tisha, for touching on how you've been able to use performance evaluations with athletes to also publish research studies. There's another question along those lines that maybe could be also. And then something I didn't mention is each speaker was just invited to talk about a specific topic, but each of them work with a wide range of patient populations. So all of them are great aspects to kind of talk and discuss some of these as well. But back to the 50-50 or some other division.
I always have a hard time putting a number on this because it's really difficult to separate what are you explicitly calling clinical care and what are you explicitly calling research, because during our clinical case reviews, that is where a lot of our research questions are generated. So we can come up with something that we think our motion capture assessment isn't addressing accurately that leads to a new research direction. And that's why I think we try to keep our research directions really in line with the clinical need. So in that respect, it's hard to really pinpoint what's clinical and what's research. For me, it just kind of depends on time of the year. Like summer and around school breaks, we tend to see more clinical cases, and when grants are due, we tend to be more grant heavy. But I think everyone's got their own kind of unique split depending on the institution needs.
Yeah, I'd say the same. I think it depends a lot about your institution. I do feel as though either there needs to be some cognizance of if you're going to see a patient, is there going to be a clinical benefit to that one patient? And that's what drives a clinical referral versus a research question. So for us here now, you know, we have worked really well with our spine team, and we've talked about, well, you know, at this point in time, there's specific patients that they have questions on that could be a clinical referral. So in other words, should I fuse to the pelvis? I want to do a gait analysis to see pelvic motion and relative to spine and see, or vice versa, and see how that might impact them long term. That's a clinical question that I can give a clinical answer to. But if I'm just looking at it from, you know, this is not going to impact their clinical decision making at this time, then we're going to see that patient more for a research portion. So I do think that we have to be cognizant. Gait analysis is expensive. Not all insurances pay. People have deductibles. So I've become much more cognizant of who I will accept as a clinical patient versus a research patient.
Fantastic. I was just going to chime in real quick. Each institution, especially within pediatrics, I will say that their summer is very busy because that's when all the kids are out of school. So trying to find a time to schedule appointments usually fall within the summer months. So that's just some interesting piece when it comes to scheduling. But with that being said, we are at 1 o'clock on the East Coast. So thank you all so much for tuning in for our IWB monthly meeting in collaboration with GCMAS. A couple things, if you are interested in becoming a member of either organization, those information has been shared again into the meeting chat. IWB has their holiday meeting that will be coming up in December, and GCMAS has a webinar series that is going to be open to all with Dr. Erin Mannon. So that's going to be Friday, December 8th at 12 p.m. Central Time. So I really would like to recommend and encourage everyone to tune in to those and sign up as well. Thank you all for your time. I'll see you all next month.